So thank you everyone for joining us for the first of 4 sessions of the Leukemia Research Foundation's New and Emerging Treatment Series. The topic of this session is CML, and we're joined by Dr. Paul Koller from City of Hope in Los Angeles, who will share some slides about the latest treatments and research for CML and respond to questions from participants. My name is Lindsay White, and I'm the Director of Programs and Partnerships at the Leukemia Research Foundation. I'd like to take a moment to recognize the supporters of this series, AstraZeneca, Autolus, Kite, Merck, and Pfizer. And we're going to just talk briefly about the Leukemia Research Foundation, then I'll introduce our speaker and get things underway. The Foundation's mission is to cure leukemia by funding innovative research and to support patients and families. The Foundation has raised over $95 million to support its mission since our founding in 1946 and has funded research grants to over 700 investigators worldwide. Our support programs for leukemia patients and loved ones include information and resources, education programs, financial assistance, and a directory of other helpful organizations on our website. For today's program, all participants will be muted, but we welcome your questions in the Q&A box at the bottom of your Zoom screen. If you already submitted a question at the registration, please know that we have your questions. We'll do our best to cover as many as possible. After today's program, you'll be sent a brief questionnaire through email. Please take a moment, if you can, to complete the evaluation so that we can improve our future programs. Also, this program will be recorded and a link will be sent to all participants and registrants after, after the program concludes. And we hope that you'll share it with anyone who might be interested. So we're grateful today to have Dr. Paul Koller. Dr. Koller is an assistant professor in the Department of Hematology and Hematopoietic cell transplantation in the Division of Leukemia at City of Hope Comprehensive Cancer Center in Duarte, California. He is actively involved in clinical and translational research for the treatment of patients with leukemia. His particular focus is in developmental therapeutics in acute and chronic leukemia, including biologically rational targeted therapy and novel combination therapies. He is a primary investigator on numerous trials in chronic myeloid leukemia, acute myeloid leukemia, acute lymphoid leukemia, and high-risk myelodysplastic syndrome. Dr. Koller, thank you so much for joining us today. And please let's get things started with an overview of the latest treatments, research, and trials for CML.
Thank you, Lindsay. So I guess we'll...
Do you see the slides now?
I do.
There we go. Okay.
So I'd like to thank the Leukemia Research Foundation for having me to discuss chronic myeloid leukemia, the new and emerging treatments in 2025. As Lindsay said, my name is Paul Koller, and I work at City of Hope in Duarte, California. So this is my obligatory financial disclosures slide. I think we can just move on quickly from that. And we can focus a little bit more on CML and how people get it. So I imagine that many people listening were either personally or kind of adjacent personally affected in this way. So, people present with CML actually typically with no symptoms at all. If they do have symptoms, maybe they'll say they had some fatigue. Maybe they'll say that they were eating a little bit less, that they lost some weight, that they had some fevers, and they had some kind of abdominal fullness in an organ called the spleen, which a lot of people had never heard of until they were diagnosed with CML. When they get a CBC, and this is typically how they're diagnosed, they have a very high white count. They can have a normal or high platelet count, and then they have these cells in their differential called basophils. And when we look at a peripheral smear, there's like all the cells, not just blasts and not just good cells, but like all the cells. And we do a bone marrow, there's lots of cells. And I would be remiss if I, as a hematologist, when describing cells, didn't show you cells. So in A here, this would be a peripheral cell, and you can see the purple cells they all look a little different. And those would be cells of kind of varying maturation. Number or letter B, the slide B, is a bone marrow aspirate, and it's just tons of cells. So there's no white in there. Typically, there's like white interspersed with pink and red, and here it's just pink and red, which is called hypercellular when we look at the bone marrow biopsy and aspirate. And C is an aspirate, and on the aspirate here, again, the purple cells, which are the cells which are really white cells, you see they all look a little different, as opposed to with an acute leukemia, they'd all kind of look like clones. And so this is like hallmark of CML. And then really the like kind of what kind of cinches or concludes the diagnosis is the presence of this thing called the Philadelphia chromosome. And here you have a karyotype, and karyotype means it's within a cell, it's all the chromosomes in a cell, and it goes from 1 to 22 with X and Y. And these are all the cells. And if you see, there's an arrow to 9 and an arrow to 22 here, and the Philadelphia chromosome is the small chromosome 22. And we'll go to the next slide to kind of blow that up and to look at this under a cartoon. And so this is what's going on. So you have a normal chromosome 9 and a normal chromosome 22. And when a stem cell happened to divide, a part of chromosome 9 kind of merges with the part of chromosome 22 and vice versa. So you don't lose any genetic material, but what you end up having is this what's called a fusion protein. A part of BCR and a part of ABL are fused together. And the way I describe it in clinic is it's like, and I'm looking up because the lights are up, but it's like being in a room with the lights on and the light switch doesn't work. And that's where you get all those cells. And so our job is to turn the lights off sometimes. Next slide. So how do people kind of present with CML? What do we look at like at the beginning? So we just kind of have to acknowledge that there are 3 phases of CML. There's the chronic phase, which is how most people are diagnosed. And that we kind of talked about previously, but again, it's usually asymptomatic. Occasionally there's some fatigue. Sometimes there's night sweats. There's weight loss. Usually people kind of like this, but then it gets a little too much. There's abdominal fullness, which ends up being splenomegaly. And then on a CBC, there's elevated white count. And then when we look at the blasts, there's less than 15%. With the next phase, there's an accelerated phase, which is really just like the phase between chronic and blast phase. And think of this like a yellow light. We'll kind of come back to this like traffic light concept later in the talk in other spaces, but I guess we're simple. So we like lights, and we like traffic lights and room lights and stuff. So I apologize if we're using kind of the same analogies over and over again. And then there's a blast phase, and this is a really difficult kind of disease state to be in, and it's incredibly challenging. So like all the progress we've made, and we're going to talk about a lot, like we still like really struggle with blast phase CML, but that's where the blasts are greater than 30%, and or there's blast outside of the bone marrow and the spleen. And there are some other things that are happening in blast phase, But I think kind of the simple takeaway is more than 30% blast. So when someone comes with CML, typically, and they're in chronic phase, typically the average is they have 3 to 5 years before they progress to accelerated and then progress to blast phase. And then blast phase without treatment is an acute leukemia and is like fairly quickly fatal. Most people in the developed world are diagnosed in chronic phase and are usually asymptomatic over and over again, where we kind of talk about this. And then accelerated phase and blast phase, like kind of the progression is like a continuum. It just things kind of slowly continue to get worse. There are additional cytogenetic changes. The blast count goes up, pain gets worse, fevers get higher, spleen gets bigger, et cetera, et cetera. And really the initial treatment goal is to prevent progression of blast phase CML. And that's really like when you initially see us, like that's our goal. That and like making you tolerate the therapy is really what we want you to do. If we can go to the next slide. So tyrosine kinase inhibitors for CML. I'm sure most of the people on this call are familiar with how important these are, because this is like totally changed how we treat CML. And I would bet that there are still people, and perhaps maybe even on this call, that were directly benefited from the imatinib approval in 2001. And it cannot be overstated how important this development was. And it's really like a modern medical miracle that we have imatinib. Kind of shortly afterwards, we realized like this was incredible, but there are still people that need more. So we developed dasatinib, nilotinib, and bosutinib. These are the years that they were FDA approved, 2006, 7, and 12. And they're now approved in all lines. So imatinib and all the second generation TKIs are approved for all lines. Around the time of the second generation development, we realized that there was this specific mutation called a T315I mutation. It kind of popped these drugs out of the binding pocket. And so ponatinib was developed specifically for this mutation. It was approved in 2012, and it's approved in the third line and with this mutation. And then in the last 5 years or so, we've had this myristoyl binding pocket inhibitor called asciminib or Scemblix. It was first approved for relapsed CML in 2001, and then last year was approved in all lines. It's active in the T315I mutation patients. And then there are other non-TKI therapies like interferon, omacitaxine, and transplant. And then to the left, or to the left, is this kind of cartoon of the BCR-ABL fusion protein with the ABL1 binding pockets, the ATP binding pocket where bosutinib, dasatinib, imatinib, nilotinib, and ponatinib are bind, and then this myristoyl binding pocket of asciminib, which is like obviously different. And I think it's important to note that it is like a new, very novel drug in that regard, and it's something that we're very excited about in the field. Next slide. So CML and coexisting medical conditions. I think that like when you meet and talk with your, after you're diagnosed with CML and you're meeting with your oncologist or hematologist to talk about where to start, I think this is like where a lot of our kind of thinking goes as to which drug to put you on. And a lot of it is the goal is to be like kind of patient concordance. So, we have 5 now frontline drugs. And so we want to make sure that we're picking the best drug for you, because actually no drug has been shown to improve the overall survival compared to imatinib. And so we kind of look at all the comorbidities of the patient, including cardiovascular, diabetes, pulmonary, liver, kidney, and financial. And I think we then look at that, and then we will make a kind of collective decision as to what the best drug is. And here is it's an older chart looking at the comorbidity and the preferred TKI. And I say older because it doesn't include asciminib, but I think it's important because we haven't really worked out where asciminib goes. And so it kind of stands alone in this kind of how we pick the frontline drug. And so I think I would imagine in the next few years or so we're able to kind of sort that out. But in the meantime, I think asciminib has its own kind of benefits and its own issues that I think kind of set it alone. Next slide. So we will then kind of subsequently talk about milestones. And I really apologize for how this slide blows up. But I think you can get a sense of how much leukemia is in your body. And then at different time points and different milestones. So if you look at what a CHR here is, a complete hematologic response. That's when your CBC or your blood counts are normal. I mean, you still have a significant amount of leukemia in your body. Even for a complete cytogenetic response, which is less than 1% of a PCR, you still have 10 times 10 to the 10th cells in your body. And that's why we need to continue treating you, even with a complete cytogenetic response. Now, the great thing about a complete cytogenetic response is it's actually the most important milestone for long-term survivability. But you can still see that there's a lot of leukemia there. For major molecular response, again, this is the important milestone for thinking about a treatment-free remission. The timing of this major molecular response, and this is a typical endpoint for clinical trials, and there's still a lot of leukemia left. And even for a complete molecular remission, which is this CMR here, you still see a lot of leukemia left. And so, this kind of is an aside as to how much we're missing, even with quote undetectable disease, and the need to kind of continue therapy until everyone agrees it's time to kind of attempt a treatment-free remission. And this kind of tells you why treatment-free remissions are not always successful, even with patients with a complete molecular remission. You want to go to the next slide? So I've been alluding to response criteria, milestones, and here there's this thing called the NCCN, and the NCCN is where a bunch of leukemia experts get together and kind of talk about the state of play for chronic myeloid leukemia. There's a physician part, and there's actually also a patient part. And I think Lindsay's going to kind of give you a little bit more information on that later. But there is things for you. And for us, there's this kind of nice slide here kind of showing where you need to be at certain points. So, I think most people here have probably driven a car or seen a stoplight. So you could imagine that green is go, Red is red is red is stop, is not good, and then yellow or orange here, and orange may be closer to red, but yellow is like kind of yellow and orange are in between. So like, over 10% at 3 months, like you want to make sure everything's going okay. And then it's 6 to 12 months where you get to like less than 1%. And then here the light green is like you're gonna be like good from a survivability standpoint, but you may not be able to stop the medicine. And then this like green less than 1% is, you could at some point think about like coming off of the TKIs. If you want to go to the next slide. So we've talked about coming off the TKIs, and I've mentioned treatment-free remission, but this is the criteria for stopping. According to the NCCN guidelines. I used the 2024 because they had a nice little table, but it hasn't changed much. The table is no longer there. It's kind of text, so it doesn't port over to a talk as well. But discontinuation can be considered if you're over 18, if you had chronic phase CML, if you have a quantifiable BCR-ABL transcript, if you've been on therapy for 3 years or more, and you've had less than 0.01 for 2 years or more, and you can check the PCR on a like routinely. And actually, that is one of the things that I find stops people from attempting a treatment-free remission. We can see in the next slide why that is. So the stopping criteria for stopping tyrosine kinase inhibitors in terms of how often we want to check, it's monthly or every other month for the first 6 months, every 2 months for months 7 to 12, and then every 3 months afterwards. And then once you lose your major molecular remission, you need to check monthly until they're back in a major molecular remission, and then check every 3 months afterwards. And really, it's the checking monthly. Usually these people, usually the people that you're attempting TFRs with have kind of gotten used to like, taking the medicine every day and having their PCR checked every 3 to 6 months. So they really like that, and they're not looking forward to this like monthly checks and this unknown as to whether their leukemia will come back. But the success rate is in the literature 50%, with like kind of following the guidelines that we have now, and that 98% of people will respond after reintroduction if they fail. And then I think we usually guess about 20% of people can reasonably achieve this with our treatment approaches now. We want to go to the next one. And so this is like the first study looking at the long-term follow-up of a TFR attempt. And I really hate showing Kaplan-Meier curves like to patients. And Kaplan-Meier curves are these curves where you kind of see survival and months out. But here it's pretty obvious, like all the events happen at the beginning. This is why you check so much at the beginning. And then once you get out after 2 months, like nothing really happens. And these people are probably cured, but we don't really know that. And that's why we check them, every 3 months really indefinitely. But like this I think is a pretty, the picture kind of tells you when everything happens, and which is and kind of tells you why we look so carefully like right at the beginning. Next slide. And we are not going to talk about this in any detail at all, but I just want to tell you that when you've done your TFR and you failed, you can try again. And we're doing studies showing that. So here's just a table with a few studies like looking at this as the opportunity for a second TFR attempt. And so just know that you can do it again. So it's not just a one chance, one shot. Next slide. this is where we're kind of transition into like what's going on in the field. Um, so we've really been like kind of refining two drugs at this point, a drug called ponatinib and a drug called asciminib, and this is where we'll kind of go into a little bit more detail. I think this is like the key slide from the OPTIC trial, and the OPTIC trial basically looked at doses of ponatinib. What we learned with ponatinib is dose. With the higher dose, we saw a lot of these arterial occlusive events. And it's the reason that it's not approved frontline. And we also found with dose reductions that the rate of arterial events was less. So this study basically did prospectively what we were seeing kind of what we were seeing retrospectively, and kind of told us that, you know, if you start at a high dose and get a deeper response to a BCR-ABL less than 1%, and then you lowered the dose to this 15 milligram dose, ponatinib was actually fairly well tolerated. And here are the kind of response rates. You can see like the kind of hit them hard early and then lower the dose fast does seem to be the optimal dose. And this is kind of what we have learned from the OPTIC. And we'll talk about this like kind of dose modification strategy later. It's something that we're really focusing on in the field, but we can go to the next slide. So asciminib, which is like the new exciting drug, the first, which is this like myristoyl binding pocket inhibitor of BCR-ABL. It's a novel targeted agent here, very exciting. When compared to bosutinib in third line plus patients, you see it was much better than bosutinib. There are about 25% of patients achieved an MMR versus 13% on bosutinib. And then, as that study wrapped up, we introduced a frontline study. And again, I'm really sorry for showing like a curve. I like the bar graphs better. But yellow is asciminib and blue is everything else. And it's the percent of people that get a BCR-ABL of less than 1% at what week. And you can see that asciminib got more people to less than 1% than the other TKIs. And that's a study called Ask for First. If we go to the next slide, and this was presented at ASCO a year ago, and then published in the New England Journal of Medicine as well. And then again, here I do apologize for this, but we'll focus on the like kind of the salient points here. That the side effects with asciminib are better than all the other ones. And Lindsay, if you can just put for the asciminib grade 3 side effects, you can see they're 38% of at least one adverse event. And then for all comparators, which is the last column for grade 3, these are like the kind of clinically relevant one. It's 49%, and 38 is less than 49, and that's like that's just what it is. And you can look at the rest of them here, but really I think that's the important takeaway. We'll go to the next slide. So like, where are we going? What's next? Like, what do we have kind of coming down the chute? Well, we have a medicine called, and I'm really sorry for this, olverembatinib. And I've said it like 1,000 times at this point, but I always say it like that. But it's very similar to ponatinib, but actually very interestingly is active in patients who have failed or resistant to ponatinib. And there is an upcoming phase 3 study that's going to look at this drug. It's actually already approved in China, and it's very, very active. There's another drug called vodobatinib that's similar to a second generation TKI because it doesn't have activity against T315I, but it is also active. I'm not sure where we are from a development standpoint with this drug. And then there are 3 drugs with letters and numbers that are earlier on. There's TGRX and the TERN compound. Those are very similar to asciminib, and they're in phase 1 studies. And then there's this EVLN or ELVN 001, which is similar to ponatinib. It's also in a phase 1 study. And so there are drugs coming, but they're relatively like early in the developmental cycle. Next slide. So we're also looking into novel approaches and combinations. There's a lot of interest in like lower doses with less dose interruptions, which may be better, more tolerable, less side effects, better response rates, et cetera. Asciminib, because it binds to a different binding pocket, kind of allows us to think about combining TKIs. It never really made sense to combine imatinib with ponatinib because they were competing for the same space. Asciminib and ponatinib, for instance, can in theory bind to the same molecule, and so that's something that there is a lot of interest in the field. And then different targeted pathways as addition to standard TKIs, including like a JAK-STAT inhibitor like Jakafi, which is been of interest in the field for a while. And those there's always things kind of coming out. Does not seem to be like a leader at this point in terms of that strategy. Next slide. And then I think that kind of wraps everything up. I'd love to take questions, and I look forward to like hearing what we have to talk about.
Great. Well, thank you so much for that. I think that was super helpful. I wanted to clarify one thing. You said that olverembatinib.
Mhm.
Now, did you say that one's in a phase 3 trial or going into a phase 3 trial?
Yeah.
Okay. So
Yeah.
that sounds like that's a good promising development for this group and something different from what we've
Yes.
seen.
Yeah.
Okay.
Yeah. The phase 1 study was recently published, and we're like currently working on the kind of registrational, like similar to the asciminib versus bosutinib study we showed you earlier.
Great. Okay, and then also you mentioned PCR testing, and I just wanted to talk a little bit about that to make sure everybody understands, what that is and why it's important. So I will mention, and I'm going to share my screen real quick. We do have some information on our website about various types of testing that are regularly done for patients. So this is a link to a page on our website, leukemiarf.org, and then leukemia, and then leukemiarf.org patients resources. And in those web pages, we have some information on various testing and diagnostics. So I was wondering if you could just talk briefly about, what do clinicians see in the testing and how is it helpful for you as you kind of look at a patient going forward, whether they're in treatment or actually in treatment-free remission?
Yeah, so that's a great question. And actually testing is something that has kind of like gone hand in hand with the development of therapeutics. So I showed you a karyotype because the pictures are nice. Um, and then there's fish, which is more accurate. So karyotype looks at 20 cells that are dividing, and it's actually fairly onerous. The cells have to be dividing. You have to like take them out, you have to culture them, you actually then have to look at the chromosomes, and then you have to have a technician like see where these changes are. There's a next thing called fish. And fish is fluorescent in situ hybridization. FISH, that's where the fish comes from. And fish basically takes like a red probe and a green probe, and when you have a BCR-ABL, the red and the green probe becomes a yellow probe, and they're like right next to each other. And we do that on 200 cells, so you can get like the sensitivity of like 1 in 100, basically a 1 in 200, and that's where the cytogenetic response comes from. It's less than 1%. It's not an accident here. Um, and then we develop PCR. And PCR basically, you have this like long fusion protein, and we cut at a specific spot and we amplify one way, and we cut at another spot and we amplify the other way. And we actually then kind of look and see if we have like a short thing or if it just kind of disappears into space. And if we have that short thing, and I'm using my hand here for on purpose, if you have that short thing, it'll stack, and we just can count it. And so that's where like the PCR comes from. That's where like the number comes from. And that's typically when we're talking about TFR and these percentages less than 1%. That's where those come from. And the issue though is sometimes the BCR and the ABL fuse at a point where like we don't have probes to amplify both ways, and you get these like, it's like, there's like less than 5% of CMLs are like this, but you get these PCR negative but fish positive or karyotype positive CMLs, and those like respond well to therapy, but we actually the issue becomes like how deep we can see the response, and then when you get to like a TFR, how like how you can do that, because we want you to be way less detectable than you would be with a fish, and that's just not possible.
Great. So as I said, if anybody has questions or wants some further information, they can look on our website to find some more information about those tests. And also, I'm going to include a link in the chat to the NCCN guidelines for patients and caregivers, so that you'll have anybody on the call who wants to learn some more. I highly recommend those guidelines because, as Dr. Koller mentioned, the NCCN has a panel of experts who get together regularly and discuss the latest in treatment and develop guidelines for treatment for clinicians. And then from those guidelines for clinicians, they develop guidelines for patients as well. So you can see kind of a little bit of what the information about what we just talked about testing and about symptoms and severity, et cetera, and also some questions to ask your doctor. So I think NCCN guidelines are a very good resource for patients and caregivers. So I wanted to ask a quick question that was submitted through registration that was specifically focused on adolescent onset of CML. Can you share a little bit about for patients that are maybe younger, either pediatric or young adult patients? Do you look at those patients any differently? Are there any special considerations with treatment, that kind of thing?
Yeah, so I'll talk as I have a large, like I would say young adult panel. I'm not a pediatrician, and I think the pediatricians. So we'll focus on like 18 and I'll focus on 18 and up. But I do think of them. I do think of them slightly differently. I you know, they're so we and I didn't show this, but in a lot of talks I show a slide about um the the like this your overall survival with CML, and it's actually approaching the general population for your age. Um, and so it's something that I really want to really really like hammer home when someone who's in their like 20s is diagnosed with this, that like if we can figure out a way to like get you to take your medicine every day, that you can live as long as you were supposed to in the world where you did not have CML, if you believe in that sort of thing, and so really it's about getting them to take their medicine every day, and then trying to figure out like what their goals are. And what I mean by that is like we address this early after the education and after like kind of identifying the tolerance, or kind of at the same time as like, do you want to have a family? What is like we talk about family planning, we talk about like um you know fertility preservation. We talk about if you get pregnant, what happens, that sort of thing. I think that's like an important thing to like talk about, and it can be dynamic. Maybe the 19-year-old is not really thinking about it or not interested in it, but like that same person at 27 is, or 30 or so. And so like that may be in the back of my mind, that like the answer that they give me initially is not the answer that they need to. When we get to a point where like that maybe is gonna change, like we're kind of like passing the point of no return. And as long as you're on the pills, there's always there's always an option. But really with like transplant, I think your ability to get pregnant afterwards is not. And transplant and CML is like kind of the option of last resort. But that's like something that we would kind of talk about. We would ongoing talk about. The price, I mentioned price um of the drugs. Some of these drugs are very expensive. Actually, they some of them now are going generic. So imatinib is generic and dasatinib is generic. If we think that like this person, a lot of young people like want flexibility in their life, they may not be insured all the time. They want to like, they want to do, they want to, they want to be 20, they want to be in their
Live their
20s.
lives.
Yeah.
Yeah.
And so like, it's great now that we have like two really good options for people without insurance, or that doesn't require insurance, that's like a fixed cost that's not going to go up, that actually does seem to go down. Imatinib is $50 a month. I've actually seen that I need to recheck, but it may be even cheaper on some like non-insurance options. And so like I think like we kind of take that like all together when making the decision. So yeah, it's a huge it's a huge consideration, and it's like an enormously important when having these discussions. But I think like you know establishing a rapport, like making like kind of integrating yourself into like part of the team, like making sure that we like really address like the most important thing, which is like not progressing to blast crisis and getting them to take their medicine every day, is something that like we work very hard on.
Okay. And as far as the drugs that are in development that you were talking about, and the ongoing test for asciminib, for example, you talked about kind of we're still trying to figure out how they work, and that would be like these longitudinal studies where you follow patients for a while who are on trial to determine if there are any sort of adverse issues that come up or that kind of thing?
So I think there were, Lindsay, I think there were two questions in there maybe, and correct me if
Mm.
I'm wrong, but one was like there's that list of like, what, like 5 drugs that I listed as like novel therapies. So that's, so those are, so the way that drug development works is that like you kind of identify a need and then you test compounds like at various stages. So like phase 1 would be, phase 1 is really like making sure that the drug is safe, and there like should be like some activity, but really the primary goal of a phase 1 study is safety. um, and so like it's just basically like for some of these, it's testing like kind of like increasingly higher doses of the drug to make sure that there isn't a safety signal that is important. And then typically when you get to like the highest doses, there should be some activity in CML, and there should be like a sense of activity. And these patients typically have like exhausted all their options. And so like if there's activity, that's either this or stem cell transplant. And so like the you know the the they're in various states of development. So like the TERN, the TGRX, and the EVLN compound, those are in phase 1 studies. So like really the focus is on safety. The overbimatinib is is through the phase 1. Um, and there is a recommended phase 2 dose, and the phase 2 is like where you see some activity, but they're going to just go right to the phase 3 study. um, there is a lot of activity with that drug. I have personal
Mhm.
experience with it. And so like we're going to see if it beats the kind of best available option out there, kind of in a we're looking at efficacy. Um,
Okay.
asciminib, asciminib was recently approved in the front line. It was approved in the third line and above, and in T315I setting. But when a drug is approved, we acknowledge that we don't know everything, and so there are like still studies ongoing where you look at like, dosing, like whether it's good in the second line, um, like whether it's good in other diseases entirely, blast phase, like whether it's good in different combinations. You get a kind of chance to like look to see at it in other settings so that we can provide that option to patients in other settings. And I think then I mentioned asciminib is kind of like standalone as like the first line. And the reason I think the field feels that way, and I'm kind of speaking for the field here, is that the data that came out of ASCO and was published in the New England Journal of Medicine, and I actually showed it to you, was really like the efficacy was better, and the short-term safety was better, but there wasn't long. It was all this was short term, and this is like CML is a marathon play. It's not a sprint play,
Mhm.
and so there wasn't long term. There's not long term data yet. There's short term data that's been good as a surrogate for long term data, but there's not long term data yet.
Mhm.
And um, and from a safety standpoint, there's not like long-term data, like there's not long safety data. So like we can tell you imatinib, people have been on imatinib for like 25 years now. And so like we can tell you like that, like for a third of someone's life, like being on imatinib is gonna do this. Like we can't really tell you with these other drugs. And I think that's where like you want to you kind of you have the conversation with people. It becomes a shared process. And then the prices, let's not ignore the elephant in the room. the price is more. And so like like the perfect drug that you can't get is never better than the good enough drug that you can always get. And so like you want to make sure that people get what they need, you personalize it to them.
Right. Okay, we have a question here from that was submitted online. I'm currently being treated with ponatinib. Would asciminib have been a better choice?
So, if you're having a good response, this is how we feel in CML. If you're having a good response, the choice was correct. And if you're not having a good response, we should figure out like how to get you to have a good response. So I can't tell you like specific to your example, but I can tell you that I use asciminib a lot and I use ponatinib a lot. And I feel like they're both really important drugs for us in CML. And no, I have assuming that things are going well, my guess was that ponatinib was the right choice.
I know we have at least one person on right now who actually was not treated on a timely basis for CML, and then her disease did change, and she ended up having to have, I believe, a stem cell transplant. And I just wanted to call out that even in those cases, patients can, get the treatment they need and come back stronger than ever, hopefully. But I just wanted to call that out, that these things happen, but really the most important thing is that the patient and the family of the patient actually said, whatever's happening with our family member is not working, and they went and found another option for her, and that's when the advancement of the disease was recognized, and she went to a more aggressive treatment. So maybe you could just talk a little bit. You kind of mentioned it earlier in the context of adolescence, but generally speaking, I think shared decision making is really important for this group of patients. You mentioned quality of life. The importance really of talking to your care team, not just your doctor, but also other members of the care team, about what's going on in your life, the method, the type of medication you're taking, how regularly you're taking, and to understand if there might be some other options. Do you have any kind of advice for patients and caregivers as they kind of navigate this road?
Yeah, so I always spend a lot of time like even if it's like a fifth opinion, I feel compelled to like explain to them at least the way that I explain CML, because I think like once you understand like what's going on, like the rationale for like treating it with a pill that basically like kind of like short circuits the zombies, to borrow like to borrow a term, like makes sense. And then if it makes sense, people are more likely to like kind of do what's needed. And this is why shared decision making is important in this disease, is because like I can pick the perfect medicine, but if you don't take it, then like we're not going to get anywhere. Um, and so like I feel like it's like kind of understanding what's going on like with the disease, and then always understanding the milestone. So like why are we like shooting for this percentage, and like what are we like what's the point of it, and like what to look for. And so like we always like, at least in my clinic, we always like kind of come over to the computer, and like I have to show them the PCR and they have to look at it, and we'll say like, oh, like it's you're less than 1%, that's great, or you're like less than 0.1%, like that's even better. Like, or you're undetectable, or that's amazing, or you're not, you're over 1%. This is where we need to get you, or like, this is where you are on this like kind of road to like to like where you need to be. And like I think that's where like, like making sure that like a that the person is comfortable with their team, the patient is comfortable with their team, that they at least have like some understanding of like what CML is and like what we're trying to do here, and that like they understand like what the like what our milestones are, what we're looking for to get them to like, this like long life is like really is really the is really, I think, how I at least try to initially tackle it. And then everything else is like kind of like working out the details, like making sure the medicine is tolerated, like making sure that like we have backup plans, making sure that we have like all these things. So like,
And to be clear, some people might not be taking the medicine because it's not making them feel well, right? So, maybe the adherence to the treatment is not because they forget, but it's because it's causing other issues, which is, part of the reason. So to that end, actually, I think we're going into the lightning round here because we have a couple of questions left and only a couple of minutes left. So one person asked, what can help raise platelets? And another person asked, what can help with a queasy stomach from cell, which I think is disseminated, if I'm not mistaken. And then the last one is, how can we improve a very low red blood count? So I don't know if you can
yeah.
quickly
Okay,
respond to them.
so we'll lump the platelets and the red cells together because those are cytopenias. So one of the things that I talk about when we're treating patients initially is I use a lawn. I use a lawn because a lot of people have lawns. I guess not in the Southwest. Most of it's dirt now these days, or sand, but like people have lawns. And so like if you look at a lawn from a helicopter, if it's green, you don't know what it is. It could be weeds, it could be grass. But like when you look closely, a CML lawn is weeds. And initially, we rip out all the weeds and we're left with dirt. And the grass has to grow and it takes some time. And sometimes the grass grows back really fast, but sometimes it grows slow. And those are cytopenias. So we have to dose adjust the TKI. We have to hold the TKI. Sometimes we have to give support, blood transfusions, a medicine like Promacta to help the platelets come up. But there's all these things that we can do, but like eventually we got to get rid of the weeds, or like the weeds are going to like kind of like grow into the house and affect the house, the foundation and the walls and stuff.
Mhm.
So like it's actually really hard to a subset of people, these cytopenias, and some people, they need to get a transplant because of the cytopenias.
Mhm.
um the As for the queasy stomach, um, talk to your doctor about, there's a lot of supportive care that you can get. Like there's medicines for nausea, there's timing of the day of taking the medicine. Um, you could lower the dose if you're having a good response. And then like, sometimes you just have to switch. I mean, we're kind of acknowledging that like after like exhausting like a lot of trial and error, that like sometimes you just have to try a different medicine, and kind of try the medicine that you try, you'll have more options if you're having a good response. So I think that's like the kind of the real takeaway, I think, for you is like, it you don't need to live with it forever, but like please like take your medicine until like until y'all kind of come up with a plan to like kind of hold, reduce, like kind of support or change.
Okay, great. We did get a couple other questions come in just in the last minute or two, but unfortunately we've run out of time. But I'll try and share those with you if we can maybe get some information back to those people directly. But in the meantime, I just wanted to thank you so much for your time and effort and for putting together a great presentation. I think it was super helpful. And one last time also to recognize the sponsors of the program and encourage anyone who is interested in any more information. We have 3 more programs coming up, one tomorrow on CLL, and then next week we have AML and ALL. So you can go to our website to register for those programs as well. And as I mentioned at the beginning of the program, please do look out for the survey link to give us some feedback on this. We really appreciate everybody's participation, the great questions. And Dr. Koller, thank you so much. Any parting thoughts?
No, thank you for having me. Thank you for great questions. And you know, the Leukemia Research Foundation is a wonderful organization, and I really am honored and appreciate the opportunity to do this.
Thank you. Thank you so much. Goodbye, everyone. Have a great day. Take care.